Hello, everyone. My name is Greg Holdren, and I'm a current PGY1 pharmacy resident at the University of Toledo Medical Center. And today I'm going to be talking about Apixaban versus Warfarin in patients with end-stage renal disease. So the objectives of this presentation are to review the current anticoagulation guideline recommendations for patients with end-stage renal disease, compare pharmacokinetic properties of Apixaban and Warfarin, and review journal evidence for Apixaban versus Warfarin in patients with severe renal impairment. According to the current guidelines, the 2014 ACC/AHA HRS guidelines for atrial fibrillation, they give a level 2 recommendation for warfarin with INR goal of 2 to 3 in non-valvular AFib with a CHA2DS2-VASc score greater than 2, um, and patients who have CKD or are on hemodialysis. They define CKD as a creatinine clearance less than 15 milliliters per minute. There were no recommendations in the guidelines for DOACs, as patients with end-stage renal disease were excluded from all clinical trials. The current guidelines for kidney disease recommend against routine oral anticoagulation in AFib in patients that do have end-stage renal disease due to unclear benefits and increased risk of harm in these patients. So the Aristotle trial was a trial involving Apixaban, and it showed that Apixaban was superior to warfarin in preventing stroke, DVT, pulmonary embolism in patients with atrial fibrillation. Major bleeding was significantly less in patients with Apixaban compared to the warfarin group, but one caveat of this trial was that patients with severe renal insufficiency were excluded. This was defined as any patient with a creatinine clearance of less than 25 milliliters per minute, serum creatinine greater than 2.5 milligrams per deciliter, or any patients that were on any type of hemodialysis, peritoneal dialysis, or continuous renal replacement therapy. So just some background information about Apixaban. It is a DOAC, so it's a direct, selective, and reversible inhibitor of factor Xa. Its half-life is approximately 12 hours. That's why we dose it twice daily. Very little is removed in hemodialysis. It's primarily metabolized by the liver through CYP3A4, and 27% is eliminated unchanged in the urine as the parent drug, Apixaban. So dosing and adjustments in venous thromboembolism and PE, there are no dose adjustments based on renal function. It's just the 10 milligrams twice daily for 7 days. It's kind of the loading dose, followed by 5 milligrams twice daily thereafter. You only dose adjust Apixaban in atrial fibrillation. So standard dosing in AFib is 5 milligrams twice daily, but it can be adjusted down to 2.5 milligrams twice daily. In order to meet the requirements for a dose adjustment down to 2.5 milligrams twice daily, patients need to meet two of the following three criteria. So the first criteria is an age greater than 80 years. Second criteria is a weight less than 60 kilograms. And third is a serum creatinine greater than 1.5 milligrams per deciliter. If a patient meets any two of these criteria, then we should dose adjust down to 2.5 milligrams twice daily. If they only meet one of these criteria, then it is still recommended to do 5 milligrams twice daily. So once again, they must meet two of the three in order to dose adjust downwards. So this is a study that was done, just a pharmacokinetic study that was done on Apixaban in end-stage renal disease. They looked at 7 patients that were on hemodialysis, and they received 2.5 milligrams twice daily for 8 days. Then after this, they received 5 milligrams twice daily for 8 days to see the difference in concentration that accumulated in these patients. So they were exposed, for 8 days. They were exposed for 8 days, days 1 to 8, and then measurements were taken to determine how much Apixaban was in their system. They looked at the peaks and troughs, they looked at pre and post hemodialysis levels, and they did hourly levels during dialysis. All patients were stable on dialysis 3 times a week for 4 hours per session in this study. So as you can see here, each line represents a different patient in the study. On the left side, it is the 2.5 milligram group, and these patients were all roughly around where the expected AUC or area under the curve would be in patients that were dose adjusted down to 2.5 milligrams. So the hemodialysis group were very similar to patients that would meet two of those three criteria and get dose adjusted downwards. The two dotted lines, one at 2,000 and one at roughly 5,500, those represent the therapeutic window for Apixaban, where we'd like to see patients in between to get effectiveness from the medication. On the right side of the graph, it is the 5 milligram dose in these patients that had end-stage renal disease and were on dialysis. So you can see patients were nearing the top of that range, and two patients actually far exceeded the normal therapeutic index for this drug, indicating that the concentration in their system was too high. So steady state levels with the 2.5 milligram twice daily dosing were close to the expected values for those patients who qualified for the dose reduction based on the Aristotle criteria. Steady state levels with the 2.5 milligrams twice daily were mostly above that 10th percentile for normal patients. That was the bottom dotted line that we were looking at. And supratherapeutic drug exposure was seen with the 5 milligram dose. So that was above that dotted line we were looking at. Some background information on warfarin. So warfarin is a vitamin K antagonist. It works by reducing the synthesis of clotting factors 2, 7, 9, and 10 through inhibition of vitamin K. It's 100% bioavailable. It's metabolized mainly through the liver, and a lot is excreted. 92% is eliminated in the urine as metabolites after it has already been metabolized in the liver. Typically dosed to an INR of 2 to 3 in AFib. Warfarin dosing, it's very patient-dependent dosing. There's a large variability in the CYP2C9 throughout the population, so patients can take as little as half a milligram to 1 milligram daily, all the way up to 40 or 50 milligrams daily, just depending on how quickly they metabolize the drug. At our medical center at UTMC, it started typically at 5 milligrams to 10 milligrams daily, and it's titrated by inpatient dosing algorithm that is used by the pharmacy based on daily INR. And it's usually managed by pharmacy per protocol agreement. So the first study that we looked at was a comparison of the safety and effectiveness of Apixaban versus warfarin in patients with severe renal impairment. The objective of this study was to evaluate the safety and effectiveness of Apixaban versus warfarin in this patient population. It was a single-center retrospective matched cohort study, and the primary outcome that they were looking at was major bleeding between the two groups, the Apixaban group and the warfarin group. Secondary outcome that was looked at was composite of bleeding, so any major, non-major, or minor bleeding, ischemic stroke, and recurrent VTE. The study population were patients 18 years and older. They had to receive at least one dose of Apixaban or warfarin while admitted inpatient, and they had to have severe renal impairment. For this study, severe renal impairment was broken down into 3 different stages. So severe impairment was a creatinine clearance of 15 to 20, or a serum creatinine greater than 2.5. They could have end-stage renal disease, which was a creatinine clearance less than 15. Or they could be end-stage renal disease with dialysis. This was any patient receiving hemodialysis or peritoneal dialysis. Exclusion criteria, no patients in the Apixaban group were excluded from the study, but there were many in the warfarin group that were excluded, mainly due to a supratherapeutic or subtherapeutic INR. The patients were matched 1-to-1 with 73 patients in the Apixaban group and 73 patients in the warfarin group. The baseline demographics were evenly matched between the two groups, particularly with the primary indication for the medication or the disease state that we were treating. So non-valvular AFib was matched evenly between the two groups, as well as VTE. And the HAS-BLOOD score was similar between the groups as well. So for the results, it looked like major bleeding was trending towards significance, but there was actually no significant difference between any of the primary or secondary endpoints that they were looking at. There's no difference in major bleeding, non-major bleeding, minor bleeding, any composite bleeding, stroke, or recurrent VTE between Apixaban and warfarin in these populations. Average warfarin therapy while inpatient was 3.8 days compared to 4.3 days with Apixaban. And for these patients, they were all tracked for at least 5 months post-discharge. So the Apixaban patients received 26,944 days of follow-up after discharge, whereas the warfarin patients received much longer follow-up, for average of 41,000 patient days of follow-up. This is because it is easier to follow warfarin patients outpatient because they do have to come into the anticoagulation clinic that is managing their warfarin to receive regular INRs. So follow-up is much easier in this situation. So authors concluded that no statistically significant differences between apixaban or warfarin in patients with severe renal impairment regards to bleeding risk, stroke, or VTE. There was also no statistically significant difference when it came to major bleeding or composite bleeding, and apixaban appears to be a reasonable alternative to warfarin in patients with severe renal dysfunction. Some strengths of this trial, they were matched evenly between the two groups as far as indication for the medications. It's the first study of its kind to actually look at apixaban in this patient population specifically and compare it head-to-head with warfarin, and the outcomes were appropriate for this type of study. Some limitations: it was a single center study, it was retrospective, and different doses of apixaban were used in this patient population. Anywhere from 2.5 milligrams to 10 milligrams twice daily were used, so there was no distinction between low and high dose apixaban as far as risk for bleeding or any of the primary or secondary endpoints. And also, adherence could not be monitored while outpatient. So they were not able to tell if patients were actually taking these medications. The warfarin patients were a little easier to do that because of their follow-up with anticoagulation clinics, but they were not able to tell if patients were filling these prescriptions and taking them appropriately. Another study that was looked at, it was recently published in 2018 in Circulation. It was outcomes associated with apixaban use in patients with end-stage kidney disease and atrial fibrillation in the United States. So the objective of this study was to determine patterns of apixaban use and its associated outcomes in dialysis-dependent patients with end-stage renal disease and atrial fibrillation. This was a retrospective study. It was a cohort, and it was done by looking at the Medicare beneficiaries in the United States. They have a renal data system that keeps track of all dialysis patients in the United States that are on Medicare. The outcomes that were looked at for primary, they were looking at the difference between groups in survival-free of stroke or systemic embolism, major bleeding, gastrointestinal bleeding, intracranial bleeding, and death. The study population, 25,523 patients were looked at. There were 2,351 patients on apixaban and many more screened for warfarin, but in the end they ended up being matched 1 to 3 as far as apixaban to warfarin groups. Only patients with new onset AFib were included, and they had to be on hemodialysis or peritoneal dialysis at the time that the anticoagulation prescription was issued. For the results, like I said, they were matched 1 to 3 in the cohort analysis of apixaban to warfarin. The event rate of stroke per 100 patient years was, there was no difference between the two groups. It was 12.4 events with apixaban and 11.8 events with warfarin. For the rate of major bleeding between the two groups per 100 patient years, apixaban was actually significantly less than warfarin, so less major bleeding was seen with this medication as compared to warfarin. There was no significant difference in GI bleed, intracranial bleed, or mortality risk between the two medications. So this is just the Kaplan-Meier plot of apixaban versus warfarin for major bleeding. So you can see even right at the start, they start to separate, and apixaban has less major bleeding over the whole course of therapy. So they also looked at dose reduction. So they broke up the apixaban that they were looking at into the two groups, into the 5 milligram twice daily and the 2.5 milligram twice daily, and compared each separately to warfarin. They found that 5 milligrams twice daily of apixaban had a lower risk of stroke, a lower risk of major bleed, and a lower risk of death as compared to warfarin. Whereas the 2.5 milligram dose of apixaban had no difference in risk of stroke, no difference in risk of death, but it did retain the lower risk of major bleed as compared to warfarin. This is a breakdown of the 5 milligram versus the 2.5 milligram dose, 5 milligram being in orange and 2.5 being in blue. And 5 milligram was superior to warfarin in every category, whereas the 2.5 milligram didn't show any difference. The only place where it showed a difference, where it was actually equivalent to the 5 milligram, was in the reduction of major bleeding risk. So the authors concluded that Apixaban was associated with superior safety and effectiveness outcomes in patients with end-stage renal disease on dialysis as compared with warfarin. The 2.5 milligram and 5 milligram dose were both associated with a lower risk of major bleeding, but the 5 milligram dose was associated with reduced risk of thromboembolic events and mortality, whereas the 2.5 milligram dose was not associated with these reduced risks. So the conclusion to this presentation is that Apixaban appears to be as safe and effective as warfarin for end-stage renal disease patients needing anticoagulation. Dosing strategies still remain a topic of discussion. So when to dose reduce, really, end-stage renal disease does not require a dose reduction in every situation. It's still the two of those three criteria that we are looking at when we are deciding to dose reduce to the 2.5 milligrams twice daily. So they would need to be greater than 80 years of age, less than 60 kilograms, or have a serum creatinine greater than 1.5. Any two of those three criteria are still needed to dose reduce. End-stage renal disease alone does not require dose reduction. And ultimately, it may be down to affordability in these patients, because Apixaban is still quite expensive. When comparing prices on GoodRx at many local and community pharmacies, warfarin is typically $4 for a 30-day supply of medication, whereas Apixaban remains $448 for a 30-day supply of the medication. So Apixaban does appear to be superior to warfarin in these patients, specifically the 5 milligram dose, because it does retain those decreased risk of thromboembolic events, but warfarin may be the better long-term option for anticoagulation in patients that would not be able to afford regular Apixaban. And that is everything that I have for this presentation, so thank you for your time.